Everybody, we'll get ready. I think if there's any stragglers out in the lobby, if you can just tell them to come inside, and if somebody wants to shut the doors, that would be helpful as well. All right, so welcome everybody. My name's Kyle Gibson. I'm one of the APPs for the Trauma and Acute Care Surgery line. And I had the distinct pleasure of being your moderator today. The person who was supposed to moderate actually canceled last minute, and Emily and all of them just rushed to get me to be here. So, this is what you have. All right. So I'm not a professional, but we'll try to do a good job. So
you did stay at Holiday Inn last night.
Yeah, for sure. So the goal of today is to discuss trauma and acute care surgery research, kind of what goes into your research. And for the ones who are out in the crowd who may not know this, research is a topic that is required for us to be a level 1 trauma center verified by the American College of Surgeons. So it's a big deal. It's if we don't do it, it's a deficiency. But we have a rock star cast that I'll introduce momentarily that kind of helps support that division of trauma acute care. So also we have the chair set up. We were going to start off with some cool hype music, but the firewall of the hospital drew the line at Cardi B's WAP. All right. Intro for the discussion. So to be fair, in trauma, WAP stands for whole blood, aggressive resuscitation, and plasma. All right. So obviously the version of WAP improves hemorrhagic shock outcomes, but the other gets IT involved and me in trouble. So I don't want to be in Dr. Rios' office later on. So we'll keep it PG, stick to whole blood, we'll stick to trauma resuscitation, and we'll have a good time, and we'll kind of have some questions coming from me. We'll kind of build on that, and if there's any questions from the crowd, we'll have a mic for you guys to ask as well. But I want to pause before we get into the introduction, and I want to say thank you to Dr. Holly Jones, who's a huge supporter of trauma research. I worked with her over the years, I think on the first initial research trial that we were going to look into end-tidal CO2 for hemorrhagic shock. We kind of connected early on my research career and her coming on board with NGHS. So she's a staunch advocate for what we do and how we change care. And her team sponsored this event. But I do want to give some fun facts about Dr. Jones, all right? So she's an avid golfer, all right? So don't challenge her on the golf course because you'll probably lose. Definitely a UGA fan. And her and John Daly actually went to the prom together. So two truths and a lie, maybe, all right? So let's get started with this amazing panel. We had to cut down their bios because they're so big, but their passion for trauma and acute care surgery research is even larger. So let me start off with Dr. Kuhn, Bradley Kuhn. Dr. Kuhn's a trauma and acute care surgeon here at NGMC. He currently serves as the Associate Program Director for the GME Department's General Surgery program. He received his medical degree from Wright State University. Boonshoff School of Medicine. That sounds very, very fancy. And then went to residency in Spartanburg, and then did a surgical critical care fellowship at the University of Utah Medical Center. So obviously he's board certified, or he wouldn't be working with us, but he's double boarded in general surgery and critical care. Now we have Dr. Vassie, our Clemson fan, all right? So Dr. Vassie is the trauma and acute care surgery trauma medical director. He earned his medical degree from the Medical University of South Carolina. He went into residency in Knoxville, right? And obviously double boarded, has been in the trauma game for a long time. Loves research, and obviously an advocate for our team. So now we have Morgan Kraus is a trauma nurse. and a researcher, all right? Those are her real glasses. Doesn't come with like the librarian look, so she is definitely a researcher. All right. She has more than a decade of experience in trauma, ortho, and neuro surgical care. She's co-authored multiple papers, and she's the lead for our DoD-funded prompt study on P-ROBOA outcomes. And so if you don't know what ROBOA is, or the small p in front of ROBOA, we'll probably talk about it as part of one of the questions. So she's actively involved in the national work group sponsored by the Coalition for National Trauma Research. And so great resource for us. And then we have Tapia, all right? So Dr. Raphael Tapia, he's a fourth-year general surgery resident at NGMC. He is a proud Georgia Bulldog, all right? He's actually from here. Family lives here, and so kind of in the Northeast Georgia corridor. So definitely homegrown, all right? So went to medical school at the University of Guadalajara and graduated in 2021, and he plans to pursue a surgical critical care fellowship. I think mainly they just say that so that way the surgeons are nice to them, because I feel like everybody wants to be a trauma critical care surgeon, but it's okay. We love you, and it'll hopefully be one day we can be partners and you can work for our health system. So let's get started. I'm going to pick on Dr. Vassie, and I think there's a mic, handheld mic. I see Dr. Kuhn has, and is there one more? Okay, all right. So there's two, if you guys don't mind just passing back and forth, and we'll kind of, create this as low key. If anybody wants to add to a question, a comment, but I will cut you off after 2 minutes, okay? So just we got to keep the flow going. All right, so Dr. Vassie, as medical director and an avid participant in national societies, what are the most pressing unanswered questions in trauma and acute care surgery research today?
Wow, that's a loaded question. I think, and I don't want to steal Morgan's thunder because she's probably going to be the best to speak to the details of our P-ROBOA study, but I think this is one of the topics that ROBOA, resuscitative endovascular balloon occlusion of the aorta, by the way, for resuscitation purposes, it has been a really hot topic, and the trauma world is completely divided on whether it's of the devil or the best thing since sliced bread. And fortunately, we believe in the technology here, and to the point that we were invited to participate as a part of a small group with the prompt study that's actually been very successful in our leadership here with Morgan, kind of making sure we get the right data and keeping all that and entering the data and making sure we stay up to date with our partners in the study has really been the driving force and kind of a sea change from the old-fashioned use of this technology to the new technology and the new uses for the technology. And I think we've made great strides nationally in terms of the impact that study and the work with that small group has been able to do. To the point that one of the staunchest anti-advocates of ROBOA use now is a medical advisor to the company that makes the catheter. This is, kind of, I look at it, one of the things I'm the proudest of our team for being able to participate in. And I made this point when we were first talking about how research plays a role in the Level 1 Trauma Center. And the reason it's important is because instead of being 5 or 6 years behind the curve in terms of things that really make a difference in treating our trauma patients, we're actually participating in establishing the curve. So we're putting ourselves years ahead of the average trauma center that takes care of trauma patients by participating in the research. And this is a great example. The ROBOA use is a great example of that. So that's a really hot topic. Through our RTAC collaboration, the other thing I'd mention is there's a move towards how we treat patients in terms of immobilization in the field. I mean, we all know the ills of the backboard. I mean, HAPPYs that we have, and that's now a quality measure that we're struggling to kind of participate or improve our performance in. We had a great presentation by a very passionate couple of people that are on the forefront of kind of eliminating the use of cervical collars in the field, which I think is really interesting. That's a big needle to move because you got a bunch of neurosurgeons who are, they're brain surgeons, for crying out loud, considered the smartest people on the face of the earth, along with rocket scientists, that are probably not going to be terribly in favor of that. But there's really no evidence to show us that it's a good thing to do. And there's actually some evidence that shows us it very well may be a bad thing to do. And so things that becoming a level 1 trauma center and delving into that research have brought us the opportunity to do is, put ourselves way out at the forefront of what's best for our patients. And I think that's the most important part.
Absolutely. And hopefully, just like P. Raboa, we can continue to lead in pre-hospital care, at least trauma care for sure. All right, Brad, this one's for you. Can you just maybe for some of the audience that maybe doesn't understand the process of like an IRB or what a primary investigator or sub-investigator does in clinical trials, can you just kind of give us like a 30-second elevator speech?
Yeah,
Really, 30 seconds.
A PI is a person that talks to Morgan, and IRB is the people that Morgan talks to on your behalf, is a short answer. So a PI is somebody who is the physician champion, nursing champion, clinician for a topic that will be the go-to for the multiple steps that are part of putting a paper out, being at a podium, which is usually about an 8 to 12 month process from time of question being asked to time of first presentation. We're currently in a couple of those. Morgan and I are together. But yeah, that's what they serve. They serve as the liaison for the team, for the research department, making sure that they respond to Morgan's emails in a timely fashion, and then continuing to push the clinical side.
All right. And so Morgan, obviously you've been recognized as kind of the gatekeeper with IRBs and everything. Can you kind of explain maybe for your role as a research coordinator, any barriers or kind of the most common failures of why IRB doesn't get pushed or accepted?
I will say am I supposed to turn this on? Mic person, sorry, Robbie. I will say that was definitely a learning curve that we learned from Dr. Jones and her team, and they very well set us up for success of having, an IRB blank protocol that has the verbiage of risks versus benefits and things like that. A lot of our research is retrospective, so it is exempt from IRB reviews, so it's usually a pretty quick turnaround for them to tell us that it is exempt. Where it gets a little more tricky is when we start doing multi-centers because we need data use agreements, which again, we do heavily rely on Dr. Jones and her department to help with that contracting phase, and then clinical trials. And then anytime, I think the biggest learning curve for myself and Emily and Natasha has been if there's anything reportable, tracking adverse events in the world of trauma. I feel like we've also had the opportunity of learning together with Dr. Jones and team because trauma research is so different than any other, than oncology and cardiology. They're very protocolized. Trauma is what you get when they walk in the door, and you do your best with that information. And so I would say those are our biggest challenges, not in a bad way. They just take a little more time and effort for the clinical trials and multi-centers or any, prospective observational research.
And Morgan, I guess just kind of piggybacking on that, you're definitely involved with the National Research Coalition. And I know you guys meet on kind of a yearly basis or twice a year basis. Can you kind of just tell the audience kind of the specific patient populations or mechanisms of injury that remain unrepresented. There's definitely gaps in the literature, and, I think we try to focus on those gaps here, but I just didn't know if maybe you can let the crowd know.
Yeah, the biggest thing that we discuss is rural trauma and access to care, which is where I will toot the horn of our TAC, our Regional Trauma Advisory Council. We have a phenomenal region where we all come together, trauma program, trauma providers, all of our EMS and fire agencies, including AIR, is a wonderful collaborative. And so I think that any disparities, any rural or access barriers are the hot topics. The committees that I work with, the biggest thing is no one should die because they don't live right beside a trauma center. So how can we do better as that trauma center to educate our outlying facilities and partner with them and help them own some of these processes? And I think those are the biggest areas we can improve. They're also the most challenging sometimes to get in research. They may be low income. They may have, different immigration status, different primary languages. So those do get some of the challenges of including those patients in research. And you may have some more issues with the IRB from that standpoint.
Only thing I'd add to that is in terms of our access is, trauma centers are necessary. And it, like you said, nobody wants to, we don't want folks to have poor outcomes just because they don't live near a trauma center. But at the same time, the resources of a trauma center are so demanding that it can't be like a Starbucks in Manhattan where there's one at every corner. Because, if we could just get a hold of unlimited resources, we could solve the world's problems, but those don't exist, right? So I think the importance of the RTAC, and I'll toot Kyle and Jesse's horn in terms of how it's run, is one of the models around the state of how well a group can come together. Having said that, there's still some opportunities that we can still get better with that. We're the only trauma center in our region, so how getting patients to the right care depends heavily on our EMS providers, and not only getting them here, but providing the great care, the best care that they can while they're on the way, because they're not just right around the corner. They're from Hiawassee, they're from Angel Medical, they're from, trapped under a rock at Tallulah Falls. They're everywhere. But one of the opportunities I think we have is to get the other big part of getting patients to the right place at the right time and efficiently is having cooperation from our referring centers. And I think that's one thing that we've begun to work on a little bit more heavily, because they may not show up directly here from the field. They may go to another place. They may look great for a little bit of time until they don't. How do we equip our referring centers to be able to identify sick people quickly and get them out the door very quickly? So that's one of the things that one of the having the access to all of those people in that advisory council really helps us facilitate. So we haven't really produced any research out of that. With the exception of just, the word of mouth around the state that these guys know how to do it, and they're at the forefront of making sure each region learns how to do that best. So I just want to kind of second what you said about RTACs. It's very important.
Well, we appreciate the kind words, and it's definitely a group effort as far as thinking not so much as one healthcare organization, but kind of a regional approach to the care of the injured. All right, Tapia, you've seen how people have answered questions. I just wanted to give you some time to acclimate a little bit and not be nervous and stutter your words. All right. So
all right.
You're up next. All right. So you obviously, as a medical student, you applied to multiple general surgery residencies to kind of get a spot, right? A categorical spot. So can you kind of describe maybe when you, a couple years ago, were looking for residencies, was research a priority for you? So that's the first question. And then number two, as we built this research division here at the hospital, like where do you see the residents fit into that?
Yeah, of course. When I was applying to residency, it is something that programs look at, and it's becoming more important now. That was about four or 5 years ago when I was doing that, and now it's been shown to be even more important. So most of the students, and we have a student out here in the crowd today. He's a second-year student. He's already working on research, showing you guys how important it is to be ahead and to have a rigorous amount of research behind your name. It really helps, not just for yourself, but it helps patients, and that's the most important thing. And the second part of the question was asking about residents and how we fit into that. Is that correct?
Correct.
Yep. For us, it's important to do research because we are also looking into fellowships, so that's also looked at. Not so much for having your name behind things, but showing initiative, showing that you are willing to go above and beyond and help patients, finding ways to better the care patients are getting. And that's what research is important for. Patients number one, and all the research we're doing is all being done to make sure that patients get better care in more efficient ways.
And so I know obviously you guys rotate into different surgical specialties. So obviously trauma and acute care surgery is the best, but you also do like vascular surgery. And I know you guys put out a fair amount of papers for vascular surgery. So how do you, what factors kind of influence, new evidence going to the bedside? And how do you guys maybe, let's say if you did like a rotation to one of the Piedmont site or out of the NGHS network site, and you know, hey, this is kind of like the tip of the spear, and maybe they're practicing 5 years, prior. How do you kind of mitigate those conversations?
Yeah, good question. So
Or
factors
close the gap as far as
right. So factors that influence the research getting to the bedside is how significant is the research and does it apply to our population? If it's a research that's geared towards a younger population or where we're dealing with an older population in a different scenario than what this research was done, then it might not fit the patients we're taking care of. So that's an important thing that we look at. We look at is this research that's being done, is it appropriate to apply to this patient that I'm dealing with now? So in regards to going to different facilities, which we do, we go to all over the Atlanta region. We go to Emory, we go to Piedmont, we go to Grady and Choa. And a lot of physicians do things differently everywhere we go. What I have done in the past is respectfully introduce the fact that, I saw this paper that we usually look at in my facility, and this is what it says. Have you taken a look at it? And kind of open the floor to discussion and picking their brains, seeing why they do things the way they do it. And it usually opens up a really good conversation on, oh, yeah, that's a great point. We can try that. Or in my case, I've done this, and that's why I do this. So generally, that's how I've ran into that situation. Course.
And Dr. Kuhn, so as a program director for the GME program, how do you counsel your residents on kind of those conversations, and then barriers that you may see as we try to put evidence to bedside?
Yeah, I was thinking about it as you were asking that. So I think if you look at providers alone, on our service line, there's 7 surgeons, there's 11 APPs, there's 34 residents, there's a cohort of maybe 50 STICU nurses, probably more than that, I'm underestimating. And then there's hundreds of floor nurses. And so getting one person with a passion project to have it affect 130 person list takes everybody being on board with understanding the why behind that research. And you have to really show benefit in order to get people to do more work or to add another step or to integrate something to Epic, whatever you're trying to do really has to show some validity in the research. And so understanding where those are coming from, looking for multi-center trials and trying to have needle moving studies that we can latch onto is the goal. One of the things we don't currently do in the program, which we'll be adding back in the next calendar academic year, is a journal club, which is a way for the residents to dissect papers, not really for what they have from a content standpoint, but learning how to dissect from a quality of review of literature on a monthly basis or quarterly basis. And those are good skills to have when somebody hands you a paper and says, oh, why aren't we doing things this way? Why aren't we giving, everybody ivermectin when they come in the door? Being able to dissect that piece of information and say, that's not really our patient population. It's a low quality study, low evidence, not significant data, and move on back to what you were doing before, or say that's actually a really good paper. Let me see if there's others like it. Those are the main things we try to train into the residents. I will say anecdotally, they are very, very good at acquiring procedural skills. Kyle and I have talked about this before. They can acquire hand skills and translate those in the operating room. So a vascular maneuver, they can then move into a colorectal operating room with relative ease. A lot of them can, and so that brain power is there. It's just the autonomy for the patient care, which is what inhibits them. If the attending's not willing to let the resident be the expert for that disease process, then they're inhibited, and that's a faculty development piece at that point. Then.
All right, fair enough. And so, just since you have the mic, can you just kind of describe, I guess RCTs or randomized controlled trials, and kind of sometimes the biggest barriers to those trials? And then Dr. Vassy, if you want to piggyback, just because you guys are both on some MCTs that we've done, or RCTs that we've done.
Yeah, I mean, the biggest difficulty is the confounding factors for what you're trying to study. I think that every time I look at a study, the thing I'm looking for is, are those patients well matched? And are they, the randomization piece, kind of had to take their word for it within certain, there's always a 2-line, 3-sentence paragraph about randomization, but are the groups controlled to one another? Are there going to be confounding issues? If they forget to talk about smoking on a vascular paper, you're going to throw it away. And so for trauma, there are a ton of confounders, and most of the time we don't know what those are when they come in the door. And so then we're retrospectively going through our trauma registry, and we really rely heavily on our trauma registrars to be able to not only get things like AIS, abbreviated injury score, injury severity scale, for the trauma piece, but also all the factors, the severe protein, calorie malnutrition, all the things that we have to do in EPIC for CDI queries that are so important for making sure that our patients are looking as sick as they are, and then for research are getting matched to their sickness too, so that we can actually use the data for what the data, that one factor, so P-Roboa on a 20-year-old and P-Roboa on an 85-year-old with end-stage renal disease that gets dialysis Monday, Wednesday, Friday, you can't really compare those to one another. And so there's going to be so many things. That person's, of course, going to have renal failure issues. They're coming in with renal failure issues. And so I think being able to have big enough data to supersede the inability to get out your confounders is probably the biggest difficulty of RCTs.
Yeah, the only thing I'd add to that is, a couple of things. I think it's incredibly important, and we've said this at M&M conference quite frequently, it's incredibly important to learn and teach our students and residents how to critically interpret the quality of research. Because when you read a paper, you can't just read the abstract and trust the conclusion that's been written. Especially now in the days of open journals where you can pay to have your work published and get credit for publication, and it's all well and good, but there's not a group of editors that are going to chop this up and say, well, that your conclusions are completely not supported by your data, or I need to see more elimination of the confounders, and so. And the second part of that is in terms of how we learn to do research and how we teach our residents to do research is just because of the randomization of your subjects into one group, a comparator group and a control group, is the gold standard in terms of eliminating the confounders, because it's the best way, most effective way to make sure your groups are equal. And because they're averaged and they're randomly selected. So, I had learned some really cool things going back to the national meeting, and the importance of kind of learning from your peers that you don't get to talk to every day. There are also great statistical ways of making sure that your groups are the same. And so understanding how to do that to make a good paper is the same as understanding how to interpret a paper, as whether it's good or whether it's bad. Because ultimately, when you read a paper, you're trying to decide, should I change how I do things? And that's really the ultimate goal. But if you don't know how to interpret the evidence, you can't really effectively decide because so much information out there, you can't effectively decide what should change your practice and what shouldn't. And I guess the second part of that is, how do you get that into practice? And that's a challenging part, to Dr. Kuhn's point about getting, 150 or 160 people on the same page about that. That's another learning point that we're all continuously, advancing and evolving on is, okay, we all agree that, between the 7 of us, let's just say, and our 11 APPs and our 7 trauma surgeons, we all agree that evidence is overwhelming that this is the way we should do things. But how do we make it happen in our system? And that's going to be different from facility to facility, but it's important. I mean, you can't just scream it from the mountaintop and expect everybody to do what you want them to do. They've got to know the why, and they've got to know the buy-in, and you got to mechanize that. So I think that's the biggest thing about our evolution in research, which has happened at a pace that I couldn't have even imagined when we first started thinking about becoming a level 1 trauma center. But that's part of it too, is, we want to produce good data, but we also want to interpret data that's already out there so we can continue to get better, because the ultimate goal is making sure our patients do the best we possibly can. So, that's what I'd add to that.
All right, appreciate that. And so Dr. Kuhn, he kind of had a little shout out to our trauma registrars kind of in his response. And the registrars are the backbone of the trauma program. So not only as far as research, this huge database that we can jump into for research and data mine some of those elements, but also for quality, right? So that they drive the quality ship for the trauma program, and definitely much appreciated. And for those who don't really know the historical context of the trauma program, Linda was like the OG trauma program registrar, and I would say probably when we all got here, less than 500 folks, right? And the health system hired a consultant that said, we're gonna probably at max only see 1,500, all right? And so now we're way over 3,000, all right? So the take home is that anybody can create a consulting firm and make a lot of money off healthcare, all right? But the question, right, is goes to Morgan, and just kind of describing how we can improve the use of real world data with our research, and talking about maybe clean data and kind of even our own experience from our blood papers and stuff like that.
Yeah, I think a big opportunity everybody knows is AI. And I think that is one piece that we could use to improve the data we get, to improve data we abstract. But of course, you can't do that without a human to validate. And so having those subject matter experts and really honing in on things. But the importance is just having that open communication and knowing that these registrars go through every single chart, every single data element, along with our PI coordinators, and they're the first people to notice trends or to ask those questions, help me make this make sense. And that's really where we've grown and adapted is, having someone, name dropping Linda, but having someone like Linda who is essentially the leader for the registrars is huge, because she can help, meet with us, identify areas that we need to add to our registry. So for pre-hospital blood, that may not be a requirement on a national standard, but it's very important to us because Kyle, Jesse, Dr. Creel, and our region and our state worked very hard to get pre-hospital blood. It's important for us to show outcomes. So Linda was able to intentionally reach out to other trauma centers, figure out how they track, talk to us about what's important. And so I think just having having a team who is adaptable and flexible and knowing that the research side is evolving, and it may not be the norm to track it in the registry, but we know that because of the research, trends are starting, and we can kind of get ahead of that in advancing our registry.
All right. So this one goes to Dr. Vassie. So as a PI, and I guess utilizing a technology like P-Roboa in emergency or life-threatening situations, can you just kind of describe how we balance the ethical concerns when studying such interventions, right? And we know that there could be risks, and we were involved in the TAP study as well at one point. There was definitely some risk as well. So maybe just kind of describe those to the crowd.
Yeah, I mean, just to expand a little bit, I'll go back to the IRB discussion we were having a little bit earlier. I mean, that is there to protect the rights of the people that we study. Just to be perfectly clear for those that might not fully understand why that has to happen. They're there to be our ethical backbone in our conscience in terms of making sure we're not doing something to a patient that's potentially harmful just for the purposes of learning. And so our biggest challenge with trauma studies, especially those that involve resuscitation, is that one, they're hard to randomize because the patients show up and you have to decide what to do yesterday at the drop of a hat within minutes. So it's really, really difficult to randomize. And so, and the other challenge that we have in terms of that is, if we're studying an intervention, we have to believe in the intervention first. Because if we didn't believe in the benefits of P-Roboa Pro, for instance, it would really not be ethical for us to apply it to patients that are at risk of harm, because it's an emergent procedure. It's a high acuity procedure. It has to be done very quickly. There are certain complications that are known to be associated with that procedure. And so, we always have to balance, what we're looking at in terms of its potential effect. And so that we became part of that group, the Centers of Excellence group associated with industry, not because they saw us as fertile ground to study their product, but because we already believed in the product and we're using the product, and they sought us out because we've done that. And I think that's the other important ethical consideration, because one of the biggest criticisms that Roboa research had gotten recently was that it was industry sponsored, and was sponsored by the company that made the catheter. And on its surface, that raised a lot of concerns. But that's why it's important to have that IRB, that's important to have that conscience, it's important to be able to put down on paper and prove that we didn't get involved in the study because they helped fund it. We got involved in the study because we believed in the product, and we wanted to prove why we believed in it. And so you got to do it for the right reasons, right? And so there's a lot of different reasons we might undertake a research study. It may be to solve a local problem. It may be something we get frustrated with. We see this happen, and then it leads to this that's an undesirable outcome. How better can we look at what happens in between to make it better and avoid that outcome? It may be going to a meeting and seeing what the hot topics are, just like the first question you asked. So all those things are really important, but ultimately, it starts and ends with the desire to make patient care better, and to make sure that everything we do is guided by that principle, no matter who's paying the bill or supplying the materials or doing the data analysis or helping write the paper. It's all got to be focused on making patients better with as little risk as possible.
Fair enough. Let's jump to Dr. Kuhn and talk about collaborations and specifically international collaborations. So I don't think a lot of people know, maybe in this room, your passion in the Dominican Republic and what you're doing in the DR. And then kind of how it started, what you're doing currently, and then maybe Tapia, describe your experience in the DR as well. And then maybe just kind of talk about how we can grow that as far as a program and maybe an institution when we talk global surgery.
Yeah, there's certainly a lot of facilities, a lot of providers doing it a lot better than I am. So that would be the biggest thing for us as a system, just to answer the question backwards, would be to look at who's already doing it well and try to emulate them. Loma Linda, Indiana University, to name a few, that are doing international global surgical care very well, which is hard to do because we need a lot. We're prima donnas. We can't just show up and hand out hypertensive medications. We need an OR, we need staff, we need anesthesia, we need lights, we need tools for the most part. And so it's hard to do global surgical research. In the DR, we haven't done anything formalized in terms of a partnership, but we have taken some of our study materials, mainly our Myriad from Aroa and some Roboa catheters down to the Dominican Republic to share with the surgical colleagues that are there in country, the indigenous operators. And so they have responded similar to like a kid in a candy shop. Just we didn't realize, we couldn't even dream that this was a way that you could help somebody. And so Dr. Tapia was present in one of these, just to stick on Roboa, not that that's what we're all here for, but easiest example to give. They were given a scenario where there's a young person that has a shattered spleen and the surgeon is 30 minutes away. The person comes in with a blood pressure of 60 and you have 2 units of blood, because I'd already tracked that out that morning in your hospital. What are you gonna do? And their first response was check to see if they're pregnant, because they're gonna die. That was their go-to response. They had no further follow-ups at all to that. They would give the blood and they would expect that person to die in the trauma bay. So when I said, what if you could design something that would stop bleeding below the diaphragm, what would it look like? And they eventually, with 5 to 10 minutes of little mini question prompting, came up with similar to what the first generation Roboa was, which was essentially a Foley catheter in somebody's iliac artery going into the aorta. And then we pulled out the catheter and showed them. And there was a couple of the providers were actually crying because they were like so amazed that that technology had advanced to a point where they could fix a problem. And so the next steps, obviously, I'm not there enough. I'm here 51 weeks out of the year and there 1 week out of the year, is to have some kind of longitudinal care model there where we can continue to train, because that's not a procedure that you can just do because you want to. And so training and getting things like that into their hands, because they have incredible abilities, they just have no resources or limited resources. So I'll defer the rest to Dr. Tapia.
Yeah, I agree. When we showed them the demonstration of how to use the Roboa, I think they were all really impressed that they hadn't seen that before, but they were also very grateful that we were able to provide them with some of those catheters that they could have on hand. Being there and seeing their facilities and kind of what they had available, even something as simple as an ultrasound. There was one in the whole hospital, and we got it up to the operating room and it didn't work. So for them to be able to do something as simple as put a catheter in through a sheath that's already in place and shoot an x-ray and confirm the placement, which they can do, it could really impact, save one life. If it saves one life, it's important. So I really feel like that's something that's gonna help a lot of people, not just here in the US, but in other places. And I think being able to deliver those things that we're studying, whether it's the Roboa or other technology or just information to another country, is going to be life-changing for many patients. The other important thing, I think, is also keeping the communication open, which I know from just reading other articles too. People in combat zones have sometimes opened up a chat between providers where they can access trauma surgeons and ask questions and get immediate feedback on what to do in the situation where there's limited resources or maybe the surgeon hasn't done the procedure before. And I think similarly, we've been able to, touch base with them eventually every now and then. And I know Dr. Kuhn talks to them more often than I do, but keeping that communication open to be able to continuously improve what they're doing and give them feedback too on what they're doing.
Can you maybe describe like the impact, right? So, I mean, obviously very passionate kind of hearing your experience, but like, how did it change you? And do you feel once you're out, graduated career, kind of, do you feel like you're going to give back just from the experience Dr. Kuhn and the GME department gave you?
100%. The way it changed me is it made me very thankful for what we have here. We have everything we could ever need to take care of patients here. I think our hospital is truly blessed, and I always tell people from other hospitals, I feel like this hospital is really like top of the line. Not just the equipment, but the people that work here. I think that's what makes us important. And seeing what they had and what they could do with what they had, I learned things from them too. I learned what to do with minimal instruments and with only one suture for the whole case. So that was impressive. We were there teaching them, but they also taught us things. That's what keeps me wanting to continue to do that once I have the ability to do so as an attending, for sure, 100%. Yeah.
Absolutely. I think stewardship's probably one of the things you bring home, probably.
Yeah, for sure.
And as a core value, responsible stewardship and stuff like that, you can probably teach us a lot. Based off what we do. So
yeah,
I'll let you end with that, and then we'll end with the last question, and then open up for audience questions.
Yeah, cool. I was just going to add one little side story too. They train their residents. So they have family medicine and ER residents for the austere environment that they're working in. And so one of the things they did, this was not your year, but the other year, they were intubating mannequins, similar to how we would in a sim lab here, and then they turn the lights off, and they give them a handle that doesn't have a light attached to it, and they say, okay, go ahead, and then they would like scream in their ear with the lights off, and then they would put blindfolds over them and have them try to intubate blindfolded, and they just get them so prepared for this like combat zone, austere environment that I learned a lot from how to train residents too, because they were highly confident with no resources or limited resources. They didn't know some days if there was going to be running water. They didn't know some days if there was going to be power. They needed to figure out how to scrub their hands 6 different ways, not just the one way that we all do, with Avogard or the equivalent. They would get gloves that were a size too small, just give it to them intentionally. They give them a glove size, a size and a half too big, and say, go do a central line. And so I think their training style was very militaristic, which I love as an attending, and very like the interns all wore one color. The second years all wore one color. The third years all wore one color. So you could tell exactly who the bosses and the mini bosses and the non-bosses were walking around, which was just a really cool experience. So we took a lot from them too. We don't just say that tongue in cheek, but it was a great experience.
Yeah, I think it's a huge opportunity to kind of continue that partnership and kind of figure out avenues how to grow those partnerships, because as you mentioned, it's definitely changing the landscape on how we teach our residents. When you go from Disney World, I guess Dollywood's now bigger than Disney World these days too, like Six Flags, you learn things. And I definitely appreciate your passion for that and kind of giving back.
The only thing I'd add to that, Raphael, is that's why we haze you guys. It's to make you better. That's why we scream in your ear and call you names and turn the lights off and give you gloves that don't fit and give you 17 things to do when you have time to do 3. It's all in the interest of making you better.
It's all about growth, right?
All right, so Tapia mentioned telemedicine, and we'll kind of end on that because I think it's something in the region we have opportunity to do. We had a discussion last week about tele-burn. There's tele-stroke programs. There's been research out west with kind of like the Google lenses. But where do you see the role with AI, telemedicine, maybe wearable sensors as well in the future of trauma and acute care. I guess like feedback sensors potentially. You guys do that with the Da Vinci device as well, the Da Vinci 5 feedback. That's kind of a cool thing that they do. But where do you guys see the future of trauma and acute care surgery with all those? And then we'll end with that. So if all four of you guys want to kind of talk about that, and then we'll open it up.
Yeah, I think soon, if you are operating independently, operating meaning providing care independently, it's by choice, not because of necessity. With our ability to, like, globalization, but that globalization starts regionally for us. And so Habersham, Union General, Barrow, Dahlonega, like that Lumpkin, up in the mountains of North Carolina, if you're in 2030, probably, functioning on your own and just a phone call like we would have done in the 70s, you're probably doing that out of choice, not out of necessity. And so I think we're going to be able to be at the bedside in some functional way as more of a partner remotely. There's a ton of work that Kyle mentioned in the robot surgery world that somebody can remote in from Dallas, Texas into my OR and tell me, oh, you don't do that, do that. We don't use that resource because we have partners in-house. But in those like pseudo austere, because I wouldn't call anything in Georgia austere, but in those pseudo austere environments, we can have some
South Georgia. That's austere.
We could have some real-time feedback and collaboration with partners.
Yeah, that's an excellent question. I really couple of thoughts. One, the remote in with the robotic system is up and running and ready now. I mean, it's mature. The way we operate, I think we have a great opportunity in our group to really utilize that, because our backup surgeon, instead of having to drive in and give face-to-face advice and give a second set of experienced eyes 20 minutes from now, can wake up at 2 a.m. and log into the computer in 5 minutes and see exactly what Bradley's doing at that console, and I can see exactly what the anatomy looks like, and instead of 20 minutes, in 5 minutes I can help him through a complex case. And it's just this incredible opportunity to collaborate and take advantage of each other's brain power and experience and skill that it's ready to go right now, and we just need to figure out how to incorporate it best. And a couple of other thoughts that I've really started to have some really preliminary discussions about is, as we've tended to, as acute care surgeons and trauma surgeons, we've tended to adapt robotic surgery a little bit more slowly than our elective surgery partners have. That's really gotten into the fast-paced, the fast lane with that. I think the conversations I've had with other surgeons around the country that are using robotics, we had, to Raphael's point about the facilities that we have here, I think we may be one of the only trauma and acute care surgery inpatient, non-elective surgeons that have our own Da Vinci 5 robot with a teaching console that lives in our operating room. That's an incredible opportunity that I think we can really jump on. The other thing I've started that we've been a little slow to adapt to is DAX. For you guys that don't know what DAX Copilot is utilized for in our hospital system, they have an ambient listening module that doctors can have a conversation with a patient with this ambient listening device, and AI will summarize that conversation into their note. So that's an incredibly valuable, more an efficiency tool. But if you think about what patients really want out of their interaction with their physician, they don't want to see you typing into a screen and looking over your shoulder to ask them questions. They want to see this. They want to see you sitting down and really engaging in that conversation. But we've been really slow to find an application for that. One of the things I'm really excited about is working with our AI partners, and we have great IT folks here at this facility as well. how do we make ourselves in the trauma bay more efficient? You know, one of the things we struggle with is documentation in that fast-paced, chaotic 15 or 20 minutes in the trauma bay where we're doing 100 different things and there's 20 people in there yelling things out, all of which is an important piece of information to document in real time. How can we really jump off of our technology and get those pieces of information logged without having one person having to take notes and write on their arm and write on their scrubs and put little sticky notes here and sticky notes there and then go try to find the time an hour later to go back and put that all in the electronic medical record so that we can know how we did and how we can do it better next time. So those are just some of the thoughts I have about, where we can head from here. Great research opportunities. But again, it all goes back to how can we save more lives? How can we do better for patients? How can we be better, more efficient? So again, I think we have the opportunities to really lead the way here in our facility with our people and our resources.
All right, Tapi, I'll give you 20 seconds.
Yeah, I
You can
agree.
pass if you don't want to.
Everything they said, I agree with. I think also with documentation, finding incidental findings, using AI to help us identify those things and refer patients appropriately with all the scans we get on these patients. I think that'd be another opportunity to use it as well.
That's terrible because Dr. Kuhn just left, so. All right, Morgan.
I don't have much to add, but I will say that it also lessens the burden of your trauma centers and of your burn centers when we do support telehealth, whether it's teletrauma, teleburn. We can trust the outlying facilities to take care of some patients, and we can provide the resources, the education, and sometimes they just need this person to say it's okay to keep that patient. So I think even just looking at it from a simple standpoint like that is very beneficial, especially in a large region of geography like us.
Yeah, absolutely. I think we do a fantastic job in the division of trauma acute care surgery between our input with point of care injury, robotic surgery for trauma and emergency general surgery, getting global surgery, and hopefully soon some type of teletrauma kind of partnership with our outlying facilities. So I'm going to end the questions there, and I'll open it up to the floor. I know we're kind of at somewhat time, but we're the cool club, so you guys can stay a little bit longer. And if there's any questions, we'll definitely answer. If not, there's probably still a lot of food out there, so grab and go. So, all right, any questions out in the?
While you guys are formulating your questions.
We cut you off.
Yeah, the only thing I'll add to the telemedicine part is I really see us at some point in the fairly near future having a person on call simply to do that. How we incorporate it in our schedule is TBD, but I really see that as an opportunity. There's volume out there that will support it now.
Definitely.
For those of us that answer the transfer center calls 15, 20 times in a call shift, there's definitely opportunities for sure.
I think Krill had a 40 day the other day. So, Dr. Jones, I see that you have the cube of knowledge.
Yes, I hope I don't have, okay, good. I didn't have to turn it on. I'm just so proud of this team and just what incredible work that you have all done over the last 5 years and just the amazing care that you give. And in addition to that, leading in research at the national level, at the international level, it's just been such a joy to see how you've improved patient care locally and very far beyond that. And I'm just so proud of what you've accomplished here and to work alongside you. So thank you for everything that you do. And just thinking about the difference years ago, before we had a level 1 trauma program, you were already delivering phenomenal care. How did that formalizing the research component of that and really bringing that on, how do you feel like that has improved care in our community? For example, if simply by having a formal program, how does that transform care to the average person? What do you say to them when they ask you, what makes our program different here?
Great question. I wasn't here 5 years ago before the program, right? But I just know that our program has made a big impact in the community. You can see it just by driving into the community. I think all of us are working to make patient care better in everything we do, and that's the most important thing. The research is a tool for that. It's a tool to improve that, to move it along, and always continue improving. Whether it includes our nurses, our residents, our students, anyone who's involved in it, we all have the same common goal, and I believe that's the most important part of it.
Yeah, the only thing I'd add to that is in the public, the perception is, well, a level 1 trauma center is different than a level 2. And that's partially true, but really from the clinical care perspective and the requirements to be a level 2 and a level 1, if you look at the what we call the Bible of trauma centers, the clinical requirements are exactly the same. All of the critical elements are for level 1 and level 2 providers. The only difference is residency, education, and research. And so, for us to step up and become a level 1 trauma center and a level 2 is just it just shows the community dedication that we want to train surgeons to stay in our area and provide great care, so that their kids and grandkids can get even better care than they've received. But we also want to show them that we're dedicated to figuring it out instead of just being leaders, instead of just being followers, and that's where the research part comes in.
And it truly is part of that team effort, and seeing that leadership in our community, I think, brings others along with it. As you lead in the area of trauma and acute care surgery, you can see how that inspires other specialties and other areas to improve care across the board. So that leadership is very strong, and I'm so impressed to see what you've accomplished here.
Well, I appreciate those kind words, but sometimes I think inspiring, that you could switch that phraseology to dragging, kicking, and screaming.
Yes, forcing them to succeed.
There's a little bit of that
Against their
too,
will.
and that's great.
Yeah, and
Happy to
then
do it.
having a little bit of that, challenge among colleagues to get better. Iron sharpens iron, and as you've already said, just seeing it grow over the years to fully integrate into the care pathway is so critical to becoming the tip of the spear. You can't do much with the tip of the spear without the spear itself, the clinical care, and then research being the tip of the spear and leading to make a difference. It's very clear that you've done that.
Well, as always, we appreciate the support from the beginning, for sure. Any other questions or concerns? Comments? All right, well, I got 2 amazing door prizes, what we're gonna raffle off. It's just kind of like the trauma symposium, a little bit. So I'm gonna shake. Yeah, the registration's up. Oh yeah, it is open. So if you want to come to the best trauma symposium in the state, October 2nd in Gainesville at the Linear Tech at the Ramsey Conference Center, registration is open. So
You sell yourself short. That's the best trauma symposium in the nation.
it really is, and it's a bargain too. So to the point where people are combining their symposiums into one because we outdo them. So thank you all for the support. All right, the winner of this very nice Birkin journal, coming from Europe itself, maybe some tariffs, with this nice little laurel leaf, goes to Carla McClure. All right, I'm gonna give that to you, Emily. All right, I honestly don't know what's in here, so. Okay, oh, this is like really fancy. All right, okay, all right. All right, so let me, same thing, it's a Birkin. Amanda Dana. Amanda? Dane, oh, well, it's cursive, so I'm too young to read cursive. All right, there, okay. All right, well, we appreciate the participation. I appreciate you guys always kind of being our advocates as far as the trauma and acute care surgery line. as I mentioned earlier with kind of joking with Linda, we started super small. And over the last decade, we've expanded at a rapid pace to, I would say, be definitely a powerhouse in the state when it comes to trauma and acute care surgery. And that's just not just like trauma, right? So we do the pillars of acute care surgeries: emergency general surgery, surgical critical care, so all the critical care for surgery. And then the one that we often don't talk about is surgical rescue. So being there for our surgical colleagues, helping them out, being that resource for them, and obviously be the resource for that patient to kind of get them back on their feet. So appreciate the time, and we'll kind of hang out if there's any other questions or comments. And please get the food, the chips, the drinks, and everything, and go from there. All right, thank you.